fuel to the fire, and it will lead to bleeding as well. This is the normal coagulation pathway, and I hope and I must I hope you must know these coagulation factor, because this is the physiology, and you must have gone through these thing in first year or second year. Just to refresh your memory, these the coagulation factor, there is a intrinsic pathway and extrinsic pathway. Intrinsic pathway started from as a contact factor when these factor come in contact with the collagen, and they are activated, and then they lead to the common pathway, which is the factor 8 activation. Similarly, extrinsic pathway, where the factor 7 is activated through thromboplastin or tissue factor, and then again it also converge on a factor 10, which and lead to the activated factor. In the presence of calcium and factor 5, the activated factor 10 that activate prothrombin and form thrombin, and then thrombin lead to the fibrin, convert fibrinogen to fibrin, and then fibrin monomer is joined together and form fibrin threads. Hemostasis is maintained. It is the balance between the coagulation and fibrinolysis. In normal routine, homeostasis is the maintenance of the balance of these coagulation and fibrinolysis. Normally, there is a wear and tear phenomena going on in our body, but that is going to be sealed off by activation of coagulation. But that coagulation is not uninhibited, not continue. Once it's started, it's it will not keep on going, an activation of the coagulation. It is inhibited by a system which is placed in the body, and then excessive coagulation is inhibited. So whenever this balance is out between coagulation and fibrinolysis, then there is either excessive coagulation and occlusion of the vessels, or there is excessive fibrinolysis, then there is a bleeding. Now coming back to the pathophysiology of DIC and or etiology of the DIC, it is multifactorial. Sometimes it is the massive tissue destruction, as in case of trauma, burns, product of conception. In most of the gynecology obstetric causes lead to DIC. Then there is sepsis and endothelial injury. In any case, they all lead to release of tissue factor. As I told you, in normal physiology of a coagulation pathway, the tissue factor activate the factor 7, and endothelial injury or massive tissue destruction lead to the activation of intrinsic pathway as well. Both these pathways will cause widespread microvascular coagulation and microvascular thrombus formation, and it also endothelial injury causes lead to platelet aggregation. Widespread microvascular thrombi causes vascular occlusion, activation of plasmin, and consumption of clotting factor. These three phenomena will lead to bleeding. So DIC is the disorder in which there is excessive microvascular coagulation, and that will end up as a excessive bleeding from all tissues. There are two major mechanisms that trigger DIC. Number one, release of tissue factor, as I told you, or poorly characterized procoagulant into the circulation. And then there is a widespread injury to the endothelial cells. And like in burns, tissue trauma, and procoagulants such as tissue factor can be derived from various sources, such as placenta in case of obstetric complications, tissue injury, trauma or burns, and sometimes mucus release from certain adenocarcinomas that may also act as a procoagulant and activate factor 10 that start the coagulation. There is a long list of clinical conditions that are associated with DIC. You must know some of the important, like severe infections, sepsis, trauma, burns, malignancy, obstetric complications, preeclampsia. These disorders you must know that can trigger the DIC. What are the possible consequences of DIC? These are two. There is a widespread deposition of fibrin within the vasculature and the partial occlusion of the vasculature, and then the ischemia of the severely affected organs, and that lead to multi-organ failure. And then there is a microangiopathic hemolytic anemia, which result from the fragmentation of red cell as they squeeze through the narrowed vasculature. In initial slide, I told you and in coming slide, I will also show you how this fragmentation occur. But one of the characteristic finding of DIC is also in late stages of DIC, there is a microangiopathic hemolytic anemia. Consumption of platelet and coagulation factor and activation of plasminogen leading to the hemorrhagic diathesis. There is excessive bleeding, which is the characteristic of DIC. Plasmin not only cleaves the fibrin, but it also digests factor 5 and 8. So the concentration of these factors are reduced, that may enhance the bleeding complication or aggravate the bleeding complication. DIC, there is a microthrombi infarction of the microvasculature, lead to multi-organ failure, like dyspnea, cyanosis, respiratory failure, oliguria, acute renal failure, circulatory failure, shock. And beside these, there is a microangiopathic hemolytic anemia because the red cells are fragmented and hemolyzed. Acute DIC is mostly associated with obstetric complications or major trauma dominated by bleeding diathesis, whereas chronic DIC, such as which occurs in cancer patient, tend to present as thrombotic complications. For diagnosis, first of all, there is a clinical scenario history, and there is background history for the cause. Then there is laboratory studies like CBC, which is a baseline test, which shows the hemoglobin, platelet, and TLC. PT-APT, which shows the which screen out the coagulation profile. PT for extrinsic pathway, APTT for intrinsic pathway. Then there is a fibrinogen and D-dimer test, which lead to the conclusive diagnosis for DIC. In case of CBC, we see the platelet count. In DIC, usually platelet count is reduced. And we also see the peripheral smear for fragmented RBCs. PT-APT, both are prolonged in case of DIC. Fibrinogen is low as there is a more and more microthrombi formation. So the fibrinogen is consumed and its level appear low. D-dimers are high, and it is confirmed the diagnosis of DIC. The only definite treatment is to remove the cause. If there is any obstetric complication, any trauma, burns, then the main reason is treatment is to remove the cause, and then there is a supportive treatment. If there is support of red cell, platelet, FFP, fresh frozen plasma, or any other control of infection, this all supportive will help to treat the patient. Now coming to the next two disorders of this lecture is the thrombotic thrombocytopenic purpura, which is TTP, and hemolytic uremic syndrome. Both these disorder comes under thrombotic microangiopathy. There is a microthrombi formation within the vasculature. The thrombotic microangiopathy includes a spectrum of clinical syndrome that include TTP and HUS. They are caused by insult that lead to excessive activation of platelet, which deposit as a thrombi in the small vasculature. Again, this leads to occlusion, is a partial occlusion or complete occlusion of the microvasculature. Then there is thrombocytopenia. Thrombotic microangiopathy, the main causes and its associations. In case of thrombotic thrombocytopenic purpura, the main association or cause is deficiency of ADAMTS. This is a metalloprotease enzyme that the deficiency of this enzyme lead to the TTP. It could be inherited congenital deficiency, or it could be acquired due to autoantibodies. Hemolytic uremic syndrome is, again, there is a typical variety of HUS and atypical HUS. Typical HUS occurs, the main cause is E. coli infection with 0157H7 infection that may cause the endothelial damage by Shiga-like toxin, and that trigger the activation of platelet and lead to the microthrombi. Then there is atypical HUS, which is not like slight deviation of clinical picture as well as the cause, and it is the alternate complement pathway inhibitor deficiency. There is a classic pathway of complement and there is an alternative pathway of complement. If you remember your physiology, in case of atypical HUS, there is the alternative pathway complement inhibitor deficiency that lead to this HUS. And again, it has inherited variety or an acquired. Acquired is due to autoantibody against this H factor. There are, beside these associations, there are other causes. Some drugs may cause microangiopathy, cyclosporin, chemotherapeutic drugs, then radiation, bone marrow transplant, infection, HIV, pneumococcal sepsis. It may also lead to microangiopathy. Condition associated with autoimmunity like SLE, HIV, and lymphoid neoplasm also cause thrombotic microangiopathies. This is the typical picture showing the pathophysiology of TTP. And here you can see these are the small platelets. This is the internal cross-sectional or longitudinal view of with what happened. This is the picture showing what is happening to these von Willebrand factor. And there is a microthrombi formation within the vessels, and you can appreciate in this picture that this endothelium, inside of the vessels, you can appreciate in this picture. This is endothelium. That this is the normal lumen of the vessel, and this is due to this thrombus. This is partially occluded. When the red cell passes through this partially occluded vessel, and due to the shear or mechanical trauma, these cells are fragmented. They appear as a torn paper, irregular edges on the smear. And this is the main pathophysiology of TTP and HUS. Now coming to the TTP in detail. In previous 2-3 slides, I have given you the general overview of TTP, HUS and its pathophysiology. TTP is a rare hematological disease with an average annual prevalence of 10 cases per million. One new case, an annual incidence is 1 new case per million. The TTP mostly occur during adult, 90% of all TTP cases, but some of the time it appear in child, and in case of congenital inherited deficiency of ADAM-TS13. TTP is mainly caused by autoimmune mechanism, but rarely it is inherited. It is more frequent in women as compared to the men. The TTP remains, it is a life-threatening disorder. It has got high mortality. Here I try to show the TTP HUS. These are overlapping disorders. The main pathophysiology is same. There's a microangiopathy and thrombotic microangiopathy, but there is 1 or 2 clinical feature or laboratory features are different. In case of HUS, the main features are uremia, renal failure. Then there is hemolytic anemia and thrombocytopenia. But in case of TTP, the main feature is fever, neurological symptoms, but there is hemolytic anemia and thrombocytopenia, and there is some deranged renal functions are slightly deranged, but it is not the predominant feature. The predominant feature is hemolytic anemia, thrombocytopenia, and neurological symptoms in TTP. While in HUS, the predominant features are uremia, hemolytic anemia, and thrombocytopenia. In 1964, TTP is defined as classical pentade of clinical features, which includes thrombocytopenia, microangiopathic hemolytic anemia, Now, I'm sure you must know what is microangiopathic hemolytic anemia. The whole idea of this lecture is you should know microangiopathic hemolytic anemia. Microangiopathic means the microthrombi formation within the vasculature, small vasculature, and when the red cell passes through these vasculature, they are broken down and they cause lysis of the red cell, and it is called microangiopathic hemolytic anemia. So there is a classical pentade of TTP is thrombocytopenia, microangiopathic hemolytic anemia, neurological symptoms as the microvasculature of the CNS is blocked, so that lead to the neurological symptoms. There is some deranged renal function, but it is not a predominant feature of TTP. Renal function derangement is not predominant feature of TTP. And then fever. The definition of TTP is changed over time. Initially, it was the clinical criteria when clinician diagnosed TTP. It is the multivisceral ischemic symptoms, fever, and neurological symptoms. Then there comes a standard biological criteria, the microangiopathic hemolytic anemia and severe thrombocytopenia, in the absence of other apparent causes for these things. But now it is accepted. There is a biological marker, ADAM TS13, available. If its activity and laboratory test is available to check ADAM TS13 assay, and if its activity is less than 10%, it is diagnosed as TTP, and it is the specific biological marker for TTP. In most cases, the mechanism is, most cases of TTP, the main cause is the deficiency of ADAM TS13 metalloprotease. Irrespective, it's a congenital inherited deficiency or it is the acquired deficiency due to autoantibodies. Here is the peripheral smear, which we see under the microscope. These are the normal red cells. This is the polychromatic red cell. This is any white cell, and these are the fragmented red cell. As I told you, this is the torn red paper-like appearance, and you can see there are multiple fragmented RBCs, and it is along with thrombocytopenia, it is the characteristic feature of microangiopathic hemolytic anemia. Thrombocytopenia and fragmented RBCs, which is called schistocytes, are the characteristic feature or hallmark of microangiopathic hemolytic anemia. And in microangiopathic hemolytic anemia, there are two prototype disorder, HUS and TTP. In TTP, there is a thrombocytopenia, microangiopathic hemolytic anemia, fever, and neurological symptoms. While in HUS, there is the predominant feature is renal failure, not the neurological symptoms. While the thrombocytopenia and the microangiopathic hemolytic anemia are the constant feature in both cases. Diagnosis. The mainstay of diagnosis, of course, the clinical pentade, clinical history and features. Then comes the constant features, the thrombocytopenia and microangiopathic, and characterized by schistocytes, and associated like mucosal bleeding, hemorrhage, and CNS symptoms, skin. Symptoms related to organ and ischemia infarction are there is a microvascular occlusion in the brain, and it is 60 and it occur in 60% of the patient. These neurological symptoms. Sometimes it's just a headache, or sometimes it is stroke, coma, and seizures. 25% of the cases there's ischemia of the cardiac muscle as well, and it may as myocardial infarction, MI. Sometimes there is a mesenteric ischemia, 35% of the cases, and present as abdominal pain and sometimes diarrhea. Renal manifestations are present in TTP, but they are not predominant as like HUS. So acute renal failure is unusual in TTP. So again, in baseline investigation, well, we check CBC for platelet count, and then PTFTT. Usually they are normal in TTP, while the PTFTTs are deranged in DIC, disseminated intravascular coagulation. So mainstay of like laboratory findings based on CBC, PTFTT, and peripheral smear. When we find in fragmented RBCs, normal PTFTT, and low platelet count, along with the history of fever, neurological symptoms, and some bleeding, bruises, and petechiae, we come to the conclusion of that it is a TTP. And then comes the confirmation of diagnosis is through ADAM TS13 assay. It is a TTP is a medical emergency. So after looking at the peripheral smear, one should straight go for plasmapheresis. Plasmapheresis is the mainstay of treatment. These are the few features which differentiate TTP and HUS. In clinical features, there is a pentate thrombocytopenia, microangiopathic hemolytic anemia, MAHA, mild renal involvement, fever, and CNS involvement. In case of HUS, thrombocytopenia, microangiopathic hemolytic anemia, and renal involvement, but not predominantly CNS involvement. HUS typically occurs in children, while it is the disease of adults. And here is the mechanism: is there is either is a Shiga-like toxin or complement factor disorder, but here in TTP there is a ADAM TS13 abnormalities. Now coming to the hemolytic uremic syndrome, HUS is also associated with microangiopathic hemolytic anemia and thrombocytopenia. These two features are common between these two, or if I say in DIC, HUS, and TTP. But in case of HUS, besides excuse me, microangiopathic hemolytic anemia and thrombocytopenia, there is a predominant feature of renal failure, acute renal failure, while in TTP there is a predominant feature of neurological symptoms. This picture shows that the pathophysiology of HUS. There is a history of E. coli infection H7O157, which act as a Shiga-like toxin. Patient has abdominal pain, bloody diarrhea, fevers, lethargy, and that this toxin lead to endothelial injury, and that activate the microangiopathic hemolytic anemia due to microthrombi consumption of the excessive consumption of platelet, and due to the occlusion of microvasculature in renal vasculature, it causes the acute renal failure, renal insufficiency. The characteristic feature in case of HUS are hemolytic microangiopathic hemolytic anemia, that the hemolysis along with fragmented RBCs, there is a increased fragmentation of red cell, increased LDH, thrombocytopenia, renal failure, and there are other symptoms and complications like central involvement of central nervous system, hypertension, heart failure, and retinal hemorrhages. Typical HUS is strongly associated with infection with the E. coli strain O157H7, and it causes gastroenteritis, and after some time, say about 5 to 7 days, patient may end up is acute renal failure. And with this clinical picture and laboratory diagnosis, it is like diagnosed as typical HUS. This toxin is absorbed from inflamed gastrointestinal mucosa into the circulation, where it damage the endothelial function, or it altered the endothelial cell function, and that activate the platelet activation and aggregation. In case of atypical HUS, which is not very common, is associated with defect in complement factor H, which is called membrane cofactor CD46. And these proteins prevent the excessive activation of complement pathway. When this factor is not present, then the excessive activation of alternative pathway is not inhibited, and it keep on its continuous activation lead to this phenomena of atypical HUS. Deficiency of these protein can be caused by inherited defect or acquired autoantibodies. Unlike TTP, the basis of platelet activation in typical and atypical HUS is unclear. As you remember in the first slide, the activation of platelet in TTP is due to deficiency of ADAM-TS13, which is like enzyme which cleaves the von Willebrand factor. So that uncleaved large multimer of von Willebrand factor remain in circulation due to deficiency of ADAM-TS13. So it causes the activation of platelet. However, this as HUS in HUS typical or atypical, this ADAM-TS13 is not deficient, and there is no problem with ADAM-TS13. So the phenomena why the platelet is activated may be the endothelial injury in typical in HUS. Typical HUS is, again, the treatment is supportive. Patient with it is the transfusion dialysis to support the renal failure. The same slide again, just to see the overall features or overall differences between TTP and HUS that I showed in previous slide. In clinical feature in HUS, there is a thrombocytopenia due to activation of platelet, microangiopathic hemolytic anemia, predominantly renal involvement, and sometimes it is the acute renal failure and patient needs support of dialysis. Usually it occurs in children, and there is the baseline mechanism or pathophysiology or etiology is Shiga-like toxin from infection with H7O157, and in case of alternative, when there is no history of diarrhea, then you must consider there's atypical HUS and due to complement disorder. While in case of TTPI, it is thrombocytopenia and microangiopathic hemolytic anemia, but the predominant feature is CNS involvement. And there is the main cause is ADAMS TS13 deficiency, either inherited congenital or acquired due to autoantibodies. This is the end of the lecture. If you have any question, please ask question about TTP, HUS, and DIC.